Thank you for the kind introduction. Listening so much about weight, it made me think, in good old days, there was a saying that man, meaning human beings, market, meaning stock market, and weight, finally जाएगा तो ऊपर ही. There can be little reduction, little crash, but ultimately the direction is up. I must say that has changed come 2025. You are happy to see people live longer. The other thing is the weight is reducing. Everything is being driven by GLP-1 receptor agonist and SGLT2 inhibitor that is causing weight loss. The problem is still with the stock market. We don't know when it will go up. Any which ways, I think I would be taking you through probably, I won't say the oldest because the oldest GLP-1 receptor agonist was exenatide, but we'll be taking you through liraglutide. It's very special because it is available at a lesser price, and if you want to prescribe GLP-1 receptor agonist to some of your patient who actually wants it, deserves it, is going to benefit from it, you can give it at a very economical price. This is what we know, that obesity is the center point of diabetes, blood pressure, fatty liver, and the what we typically call it as a fashion CKM syndrome. We have obesity and the diabetes, or typically inflamed fat causing hyperglycemia, driving fatty liver disease, obstructive sleep apnea, dyslipidemia, atherosclerotic cardiovascular disease, and chronic kidney disease. And we are a diversity capital, a lean, fat Indian phenotype that we know actually needs weight reduction even at a BMI of 25 or 26. One is because the visceral obesity is more, but second is because the complications are more. And so now the fact is we don't only need to reduce the blood glucose levels, but we also need to reduce it by a mechanism that confers cardiorenal protection. We targeted multiple aspects in diabetes management, moving on from triplet to octet, and GLP-1 receptor agonists are one set of molecules that successfully target at least 7 parts of the octet very, very effectively. We have GLP-1 receptor agonists acting on the pancreas, both insulin and glucagon aspect, on the liver, on the central nervous system, on the gut, renal and cardiovascular aspect. And we typically get a gut which is slow moving, a brain that is less craving, and a liver that is less fatty. To be very practical, if the GLP-1 receptor agonists are started probably a week before conference, the conference organizers can easily save 30 to 40% on the food. So the guidelines are also very clear over a period of time. They have highlighted two things: protect the organs and give a medication that causes weight loss as well as has less hypoglycemia. Now, if there is a cardiovascular disease or a renal disease, your choice is clear. But if there is no cardiovascular disease or renal disease, but if there is obesity, your choice is still clear, tending towards GLP-1 receptor agonist and SGLT2 inhibitors. We all write SGLT2 inhibitors left, right, and center, but we do not write GLP-1 receptor agonist left, right, and center because A, it is injectable, B, it is economically less viable. But fortunately, we have the solutions, and at least the finances part is improved by having a biosimilar liraglutide, which is equally effective as I will show, but improves glucose control and aids in weight loss. Now, liraglutide has been extensively studied. Probably maximum clinical data shows very convincingly that on the background of metformin, glimepiride, glitazone, adding liraglutide gives you wonderful HbA1c reduction. Lead was the program for liraglutide. It gives you an HbA1c reduction with less hypoglycemia, and there is an additional benefit of weight loss. The second important thing is we are worried about failure of anti-diabetic medications, which is most notoriously seen with sulfonylureas. liraglutide at least lasts longer than sulfonylureas, and probably the effect continues over a period of decades that was seen in the leader program. And as we discussed, the major barrier remained still the price and the access, which is being solved by the liraglutide biosimilar or the biologic. Now, whenever we say that an Indian make is available and we have a flurry of generics, we can actually tell, and we have this study in famous study in vitamin D, where something that was marketed as 60,000 unit had anything from 4,000 to 1.5 lakh unit. So let us see what liraglutide biosimilar that is marketed by Glenmark, how it fares in pharmacokinetics, and it is very clear that it gives you the same area under curve at all points in time at different concentrations and is exactly similar to that of the reference product. And then let us look at the glycemic benefits. We also looked at the strength of a randomized control trial, and this phase 3 randomized control trial where original and biosimilar liraglutide were given to 128 people each, followed up over 24 weeks, showed very convincingly that the biosimilar liraglutide gave you an equal HbA1c reduction as compared to the original liraglutide, and not only did it give you an equal HbA1c reduction, it gave you a equal or little better weight loss, and the side effect profile was more or less similar between the biosimilar and the original liraglutide. The rates of discontinuation, the adverse effects were almost similar, including nausea, asthenia, headache, so on and so forth. Now, liraglutide actually is a known molecule to control the blood glucose levels. But liraglutide was actually touted as the first effective anti-obesity medication in a dose of 3 milligrams. And we have an obesity pandemic that is driving all the diabetes, pre-diabetes, hypertension, atherosclerotic cardiovascular disease, so on and so forth. And if you look at how much is the obesity, and then if we redefine according to the newer definition, which says that weight, waste, or functional capacity impaired. So if somebody has a BMI of 24 but has dyslipidemia, osteoarthritis, there is still a reason to reduce weight for that particular person. So also if somebody has a BMI of 24 or 23 but has a raised waist circumference, is also a candidate for weight loss therapeutics. We probably will become a majority obese country. And so we have to look at what weight management therapeutics we have. Actually, what we had was essentially orlistat, which did not work that well in our population because we are a carb rich country and the fat intake is actually less as compared to the Caucasian population. But what is the flavor of the season for reducing weight is GLP-1 receptor agonist, and something that is classified as high efficacy is liraglutide and dulaglutide. Remember, liraglutide can be used as a weight management medication. Oral semaglutide is not yet approved as a weight management medication, nor dulaglutide is approved as a weight management medication. So if you have to use an on-label medication, then that is actually injectable liraglutide that is available with us. And let us try to look at whether this 3 milligram really works better, or there is a need for up titrating the 1.8 milligram dose, and does it add to the weight loss? And it does. It does result in at least 2 kg more weight loss as compared to the 1.8 milligram of liraglutide. Now obviously the second question will be, I have a approved cheaper medication that is available, which is a oral tablet. So how does it fare as compared to the orlistat? And you can clearly see that the 1.2 and 1.8 milligram dose of liraglutide also fares better as compared to orlistat. The $1,000,000 question is, are you able to up titrate up to 3 milligram? I think start from 0.6, go up to 1.2, go up to 1.8. If the patient's pocket permits and if the patient is able to tolerate, go up to 3. Otherwise, at whichever dose maximum you achieve at your pace, but let the patient be in the race of reducing the weight. And then if you look at the meta-analysis of obesity and overweight and the usage of liraglutide, it's a hands down wonderfully successful molecule. If you look at the body weight and hypoglycemia prevention, it is much better as compared to the other available molecules. And the recent fashion is to look at metabolically associated fatty liver disease. The 2024-25 guidelines have been unique in putting one more rider. Okay, you have a renal issue, you have a cardiovascular issue, consider SGLT2 inhibitor, GLP-1 receptor agonist. But if you have a fatty liver, and that is a marker of visceral fat, we are fortunate to have USGs and elastographies at our whims and fancies, and we can pick up fatty liver much better. But those are also candidates for weight loss therapeutics. The most important being GLP-1 receptor agonist, again specific to fatty liver. It has been demonstrated even in histopathologically proven studies is that usage of liraglutide not only results in weight loss but also results in reduction in the liver fat over a period of time, over and above the conventional anti-diabetic therapeutic armamentarium. So whenever you see a fatty liver, I think remember that GLP-1 receptor agonist and economically liraglutide has a proven data. And then coming to the cardiovascular benefits of liraglutide, cardiovascular outcome trials came into fashion because of SGLT2 inhibitors, but the cardiovascular outcome trials peak came with GLP-1 receptor agonist, that is tirzepatide, which showed the best benefit. Semaglutide showed a wonderful benefit, but liraglutide also showed a wonderful 13% reduction in the 3-point MACE, and the hazard ratio for all three aspects was lesser with liraglutide as compared to the placebo. So non-fatal MI, heart failure, hospitalization and stroke all reduced with liraglutide as compared to the placebo. And then you have the availability of these molecules. Liraglutide, dulaglutide, semaglutide are available with us. All are approved for diabetic treatment. Injectable SEMA is approved for weight loss, which is not available to us, but injectable Lira is the only available GLP-1 receptor agonist that is approved for both diabetes as well as a pure anti-obesity. So next time you see a plain fatty liver, a plain PCOD or a plain obesity causing sleep apnea, give it a very, very clear thought. So ladies and gentlemen, as I conclude, liraglutide has high efficacy as a glucose lowering medication. It helps in reducing the weight. Liraglutide biosimilar, which is more economical, is safe and effective and is non-inferior to the original liraglutide. It does have effect on fatty liver disease and also reduces the BMI but also visceral fat. And liraglutide biosimilar will actually make an weight loss medication that is approved, universally available and accessible to a larger segment of our population. Ladies and gentlemen, I thank you all for your patient listening, and I also express my gratitude to Team Diabetes India for having me here. Thank you one and all once.